Today we have Kamal, who is a fifth year medical student from Imperial and a good friend of mine back from first year. And he's kindly given up his evening to give us a talk on how to interpret your ABGs, VBGs, and a bit on spirometry as well. So I will hand over to him now and you can start with the presentation.
Thanks, Chang, for the introduction. Thanks for everyone that's turned up today. I know you guys are very, very busy with your placements and DPD as well. So today's session is looking to analyze ABGs. We're going to look at VBGs and look at spirometry as well. I think I'll have the chat open. So if at any point you want to interrupt me, feel free to just write on the chat. So any questions you might have throughout the presentation. So for those of you that weren't there at the beginning, I've got a quick Menti just to get an idea of how confident you are interpreting these ABGs. And I think we've got quite a big mix in today. And just the final question before we begin with the presentation, just one thing that you like to gain from today's presentation. I'm trying to make it as interactive as possible. I know it's quite difficult. Understand spirometry, okay. Interpreting ABGs. Hopefully all of you are confident when it comes to interpreting ABGs. Recap spirometry, okay. Different causes of ABG derangement. How it forms a part of a diagnosis, okay. Have a good time. Always want to have a good time. Spirometry understanding. Okay, just another few seconds for anyone else that wants to contribute. Okay, fine. So, before we start actually looking at ABGs and VBGs, just wanted to introduce the idea of blood gases. So for those of you that have been on your placements, you might have already seen these being done. You might have seen ABGs being requested, and you might have already seen the results as well. So there's two types of blood gases. There's arterial blood gases and venous blood gases. So when thinking back to basic physiology, we know that venous blood has a higher concentration of carbon dioxide and lower concentration of oxygen. So that's what we have to look out for when we're looking at the differences between arterial blood gases and venous gases. Arterial gases are a lot harder and a lot more painful to draw, and it can be quite uncomfortable and painful for the patient, whereas venous gases are quite easy to draw and can be taken when you request blood. But the overall picture can be very, very similar for arterial or venous blood gases. And that's why venous gases can be useful as well. So you're on the ward, a blood gas has just been done, and you'll get a little receipt from the machine that looks like this. So there's lots of numbers and it's quite intimidating, and you want to try and think of your diagnosis and think about the way that you're going to analyze this very, very quickly. So where do you begin from, and what information can an ABG actually give us? So what information does this give us? It gives us an idea of oxygenation. So we can look at the partial pressures of oxygen that in the blood. So how much oxygen is going from the air to the lungs and into the blood. Okay, we can think about ventilation. So the concentration of carbon dioxide in the blood. Of course, look at the pH. So the pH has to be very, very tightly controlled. And again, if I'm going too fast or too slow, just message me on the chat. And other really, really useful metrics. So we get an idea of the base excess, which can give us an idea into the pH. The lactate is extremely, extremely important. So just introducing the idea of a lactate, it gives us information about peripheral perfusion, and it gives us an idea of blood delivery to the peripheries and to the tissues. So if the lactate is at a higher level, it basically means that there's hypoperfusion of the tissues, and it means that there's anaerobic respiration, and it gives us a very, very good idea of how unwell a patient is. And it also gives us some electrolytes as well. So I was once told that oxygenation is one of the most important things when it comes to looking at ABG. So we all know that we look at ABGs to look at the acid-base balance, but actually we know that hypoxia will actually kill the patient faster than any acid-base disturbances. So we need to know whether the patient is actually hypoxic or not. And of course, you might be able to get a good indication of the patient's health by using O2 sats. So of course they should be, above 95 and close to 100. But we can also determine whether the patient is hypoxic using our ABG. And I think the key take-home message here is that the concentration of oxygen is actually dependent on the inspired oxygen. So we should think to ourselves, is the patient breathing normal room air? Have we given the patient nasal cannula, or is there high flow oxygen being delivered to the patient? And depending on which form of oxygen is actually delivered to the patient, it actually changes the partial pressure of oxygen that we'll actually expect to see. Okay. So the first piece of information that you should probably remember from this talk is that the normal PO2 should be above 10 for a healthy patient on room air. So if your patient is given high flow oxygen and has a PaO2 of 11, this probably is abnormal, because we would expect, due to the fact that the patient has been given high flow oxygen and a high percentage of inspired oxygen, we'd expect the concentration of oxygen to be a lot higher. And a really, really quick way of doing this is the PaO2 should be around 10 less than the FiO2. So the FiO2 is the inspired oxygen concentration. So this might be a bit confusing. So you can actually convert between the different types of oxygen. So say, for example, the patient is on high flow oxygen. There'll be a conversion between high flow oxygen and the inspired oxygen concentration. And from there, we can determine what our PA2 should be. So whenever you report an ABG and you mention the PaO2 of the patient, you also want to let the team know if the patient is on any oxygen or not. So again, the take-home message is that the PaO2, so oxygenation is dependent on the inspired oxygen concentration. So if the patient is on high flow oxygen, you'd expect to see a higher PaO2. So this brings us on to respiratory failure. And this is probably what you've, something that's probably relatively familiar to you from years 1 and 2. So we've got two types of respiratory failure, type 1 and type 2. So with type 1 respiratory failure, you've only got one abnormality, and that abnormality is your oxygen. Okay, so we've got an abnormality in the oxygenation. And with type 1 respiratory failure, you'd expect to see that the PaO2 is less than 8, and your carbon dioxide is completely normal. So there's nothing wrong with ventilation at all. Whereas with type 2 respiratory failure, you've got two disturbances. So you've got a disturbance with your oxygen and your carbon dioxide too. Okay, so let's talk about type 1 respiratory failure. So in type 1 respiratory failure, your lung function is impaired, but the key thing to remember is that we've got adequate ventilation. So ventilation refers to carbon dioxide. We've got adequate ventilation, but inadequate oxygenation. So oxygen is low. So one way of thinking about this is a VQ mismatch. So a VQ mismatch is probably something that you'll hear more and more this year. So VQ stands for ventilation and perfusion mismatch. Okay, so we can essentially have something like PE, which causes normal ventilation. So what would happen in a pulmonary embolism is that we would have reduced perfusion. So essentially, if you think of the lungs, you've got oxygen coming in, going to the alveoli, and you've got the capillaries that will surround this alveolus. So the key for your body is to make sure that there's enough blood going to the areas that are oxygen rich. So the there's a good blood supply to those areas that have good ventilation. So what happens in a pulmonary embolism is that you've got normal ventilation, so your lungs are working completely fine, but there's reduced perfusion because you've got a blood clot. So this can lead to a type 1 respiratory failure. So let me recap that again. So ventilation perfusion refers to, a ventilation perfusion mismatch refers to whether or not there's a good amount of blood or good amount of perfusion going to those areas that have good ventilation. So on the flip side, we can also have reduced ventilation and normal perfusion. So again, another type of VQ mismatch. So in pneumonia, for example, you're going to have consolidation and large proportions of the lungs that aren't working as well. So therefore, we're going to have reduced ventilation. And that's the case in pulmonary edema as well. But again, we've got normal perfusion. So these three things could lead to type 1 respiratory failure. Do I have any questions from what I've said so far? Okay, so moving on to type 2 respiratory failure. This is when the patient can't excrete CO2. So it's not getting enough oxygen in, and it's certainly not getting all these waste products in terms of CO2 out. So this is essentially when we've got alveolar hypoventilation. So in medicine, you'll be taught to categorize all of your causes as much as possible because there's so many. So we can think about respiratory causes and non-respiratory causes for type 2 respiratory failure. So we can have obstruction. So this could happen in COPD, where you've got large amounts of the airway that aren't working properly. And in terms of the alveolus itself, that's certainly not working properly because you've got a reduction in the surface area. You can think of infectious causes like pneumonia, which I've already discussed, with large amounts of consolidation, and pneumothorax, where you've got reduced compliance of the lungs, and non-neurological causes like Guillain-Barré. Okay, so now moving on to probably the most important part of this talk, which is thinking about acid-base balance. So we should know that the normal range of pH is between 7.35 and 7.45. And below this, we've got acidosis, and above this, we've got alkalosis. Another thing to note at this point is that our pH is controlled primarily by two organs. So we've got the lungs and the kidneys. So the lungs deal with excreting carbon dioxide, and the kidneys deal with bicarbonate and H+ ions as well. And we know that carbon dioxide is acidic, bicarbonate is basic or alkaline. Okay, so carbon dioxide is acidic and bicarbonate is alkaline. So how do we actually tackle blood gases, and what is a method? What is a really good approach to use? So the first step is to look at the pH. So it's either low or acidotic, normal or high. So what I do is, if the pH is low and we've got acidosis, we can think to ourselves, is this acidosis explained by the carbon dioxide? So is there a high carbon dioxide? And if that's the case, we know we've got a respiratory acidosis. Okay, but if the CO2 isn't high and we've still got an acidosis, it should be a metabolic acidosis, but let me just check, because we'll have a low amount of bicarbonate. On the flip side, if the pH is high, can the CO2 explain this change? So do we have low CO2? And if we do have low CO2, this will be respiratory alkalosis. And if it's not, and if we don't have a low CO2, by a process of elimination, it has to be a metabolic alkalosis. And do we have a high bicarbonate to explain this? Okay, so the first question of the day, I want you to analyze this ABG. Okay, so what I will do is, let me just open up the Menti spirituality. Don't think I can offer you that today. So hide the results. Let me go back to the question. And I'll give you a minute. If you need more, just let me know. Are we referring to CO2 being blown off? Absolutely. So when we think of the lungs, we're essentially thinking of CO2 being blown off. So that's one way we can get rid of the carbon dioxide. And if we get rid of the carbon dioxide, we can essentially increase the pH. So we've got 7 of you that have voted. If you're not sure, just put an answer down. I think there's around 14 of us on the chat. So let's give it a shot. 8 of you. Do you guys need an extra minute? I'll give you a few more seconds if anyone else is answering. Okay, it doesn't look like anyone else is answering, so I will. Okay, right. I think everyone got the answer correct. Okay, so maybe I'm going a bit too slowly then. So yeah, you're absolutely right. We've got metabolic acidosis. So if I explain this very, very quickly. So we've got a low pH because it's below. Why does metabolic acidosis and alkalosis occur? So I'll be going on to that later on. So if I explain this very, very quickly. So the pH is low, so we know it's an acidosis. So our carbon dioxide is in the normal range. So the carbon dioxide doesn't explain this low pH. So it should be metabolic in origin. So let me just check that. The bicarb is low. So therefore it's going to be a metabolic acidosis. So let me just recap this with a different way of thinking about it. So is the pH high or low? Is there a respiratory component or a metabolic component behind this? So as I've said before already, CO2 is acidic, it's controlled by the lungs, and bicarbonate is alkalotic and is controlled by the kidneys. So therefore, changes in carbon dioxide will be respiratory in origin. So these will be respiratory causes. And changes in bicarbonate will be metabolic in origin. I think we've gone through this already. If anyone wants to go back to any slide, let me know as well. Okay, so let's talk about each one in turn. Respiratory acidosis, okay? So if we think about this logically, we've got a problem with the ventilation because the lungs simply cannot get rid of this carbon dioxide. Okay, so therefore we're going to have a low pH and a high amount of carbon dioxide. So again, if we break this up into respiratory causes, neurological causes, and iatrogenic causes. So obstructive, I've already talked about. So asthma, you've got severe amounts of inflammation, and you've got the smooth muscle contracting. And in COPD, you're going to have obstruction as well. In a similar way, in restrictive disease, you've got a reduced amount of lung volume, so you're going to have respiratory acidosis. Neurological causes, with Guillain-Barré, we're going to have paralysis of the muscle, so therefore we're not going to be able to blow off this carbon dioxide. And then a really, really classic example could be the use of opiates. So we know that opiates lead to respiratory depression. And this will mean that the lungs simply can't excrete this carbon dioxide. Okay. So now moving on to respiratory alkalosis. So respiratory alkalosis, we're actually ventilating too much, right? So this is hyperventilation because we're blowing off all the carbon dioxide and more. Okay, so our pH is increasing. So the typical exam style question that you'd get would be someone that's very, very anxious. So if you think about, you guys before your tests, you guys are really, really anxious. You're breathing really, really heavily and you're breathing really, really quickly. So if you think about that, you're blowing off all that carbon dioxide and you're going to get alkalosis. If a patient is suffering from pain, they're going to be, again, breathing very, very fast. Their rest rate will go up and therefore remove this carbon dioxide. And also you might get this with hypoxia. And again, just thinking about the iatrogenic causes as well. So if we put someone on a ventilator and we've got excessive ventilation, then of course we're going to get a respiratory alkalosis too. So now thinking of metabolic acidosis. Okay, so we've got a low pH and we've also got a low bicarb. So thinking about this logically, this could be caused because we've got more acid production, or it could be caused because we've got decreased acid excretion, or we could be losing bicarbonate. Okay, and a really, really easy way of looking at the ABG and thinking to ourselves, is this a metabolic acidosis? Is if we look at the base excess. Okay, so the base excess should be between -2 and 2. If the base excess is really negative, we know we've got metabolic acidosis. So this is one of the more complex ideas that we're going to be discussing, and this is the anion gap. And you've probably heard of this term and not quite known what it was. Okay, so it basically gives us, so if we look at the formula for what an anion gap is, it's basically all the positive ions, such as sodium and potassium, minus all the negative ions, which is chlorine and bicarbonate. So we can think to ourselves, how on earth is this going to help us with thinking about metabolic acidosis? So all you really need to know is that all we need to know is that the anion gap tells us about unmeasured acids. Okay, so if we've got high anion gap, it tells us that there's unmeasured acids, and this is used for metabolic acidosis. So let me repeat that again. The anion gap can be used to classify causes of metabolic acidosis. So if you've got a high anion gap, it tells us that there's unmeasured acids in the system. Okay, so again, anion gap is used just for metabolic acidosis. Okay, and don't worry about calculating this at your stage. It's probably not required. And I think some ABGs might even give you the anion gap on the printout itself. So if we've got a high anion gap, remember we've got increased acid production. So that's all the anion gap tells us about, whether there's more or less acid in the system. So a classic example of metabolic acidosis with a high anion gap is diabetic ketoacidosis. So just to make things more interactive, does anyone know, how DKA works and why you get these ketones in the blood? Do you want to put it does anyone want to put it on the chat? No. Okay, so lack of insulin, good. Yeah, exactly. So someone's written lack of insulin means glucose isn't taken up, so body burns fat producing ketones, and that's exactly how that works. So we've got diabetic ketoacidosis in type 1 diabetes. And what happens is that we don't have enough insulin. And the body is actually burning these fats and just metabolizing these fats, and that's why we get these ketone bodies that are produced, and that's why we get this acidosis. And lactic acidosis, if someone remembers from the beginning of the session, so we've got hypoperfusion of the peripheral tissues. So if the peripheral tissues aren't getting enough oxygen, they're going to be respiring anaerobically, and they're going to be producing all this lactic acid, and that's going to lead to metabolic acidosis. Okay, so if you know if a patient is acutely unwell, and we do a VBG or an ABG, and we find out that we've got and we find out we've got high lactate and they're acidotic, it tells us how unwell a patient is. So we've got high anion gap and we've got normal anion gap. So this could be due to GI losses, so in diarrhea and Addison's as well. So this could be due to loss of bicarbonate. So if we're losing bicarbonate, we're going to have a metabolic acidosis as well. Okay, so moving on to metabolic alkalosis. Okay, so in metabolic alkalosis, we're going to have a high pH and we're going to have high amount of bicarb as well. So if we think about this again, so metabolic alkalosis can either be caused by increased bicarbonate or if we've got a reduction in the H plus concentration. Also, I think someone just messaged me saying, how can we tell if there's compensation? And we're going to be discussing compensation very soon as well. So if we think about how the body is going to be losing these protons, these H plus ions, we might have renal losses. So if we think about diuretics, these are actually probably one of the biggest causes of metabolic alkalosis that you'll see. So if someone is on diuretics, that could cause this alkalosis. And if we think about GI loss as well, so if we think about vomiting, the acid in your stomach, if that's lost, we're going to have alkalosis too. Okay, and there's a correlation between your potassium levels and the concentration of H plus as well. Okay, so hypokalemia is a cause of alkalosis. Okay, hypokalemia is a cause of alkalosis. So now thinking about compensation. Okay, so compensation is one of the ways that your body uses to keep the pH in its normal zone. So we know that the pH has to be very, very tightly regulated between 7.35 and 7.45. And say, for example, that we do have a metabolic acidosis. Okay, so our blood is slightly more on the acidic side, so it's below 7.35. So the body is thought of ways to try and compensate for this. So how can we get rid of this excess acid? Well, what we can do is we can blow off the CO2. And if we blow off the CO2, we can actually correct this pH. Okay, and the one thing to remember is that the lungs can compensate very, very quickly, whereas the kidneys take a very, very long time to compensate. It takes a very, very long time for these mechanisms in the kidney to kick in, and it takes a long time, to change the amount of bicarbonate, to excrete more bicarbonate or to retain bicarbonate. So if we've got metabolic acidosis, we can increase the amount of ventilation, we can blow off all this carbon dioxide, and we can put our pH into its normal zone. Okay. If we've got a metabolic alkalosis, theoretically, if we reduce the ventilation, we can hold on to this carbon dioxide, and this can again bring our pH back into the normal zone. But this is theoretical because, of course, if you reduce the amount of ventilation that's happening and reduce your respiratory rate, for example, you're not going to get the oxygen that you need. Okay, so this is very much theoretical. Now, moving on to respiratory acidosis. So if we retain this bicarbonate, we can correct the pH. And if we've got a respiratory alkalosis, if we excrete the bicarbonate or retain these protons, we can keep the pH in its normal zone. So I'm going to be going over this one more time. Okay, so this is our diagram from before. So step one, of course, was to look at the pH. Step two, can we look at the carbon dioxide and the bicarbonate to explain this change? And step three, is there any compensation or not? Okay. So if there's respiratory acidosis, we need the bicarbonate to compensate. If we've got a metabolic acidosis, we want to blow off the carbon dioxide. So we want the carbon dioxide to be low. And if the carbon dioxide is low, we know that compensation is happening. If there's respiratory alkalosis, okay, we want a low bicarbonate to compensate. And again, if there's metabolic alkalosis, we want a high CO2. But we talked about why this wouldn't really work in practice. So just a few more things on compensation. So we've talked about what compensation is. Now, compensation can be partial compensation or complete compensation. So let me talk about complete compensation first. What complete compensation means is that the body has compensated fully. Okay, so it's completely compensated. So if it's completely compensated, the pH will be absolutely normal. Okay, the pH will be completely normal. Whereas if there's partial compensation, the body has tried to compensate for this abnormality, but hasn't been able to fully rectify it. So therefore the pH will still be abnormal. Okay. So just to have a full recap of acid-base disturbances, and you can ask me any questions you've got. So the first thing we want to do is look at the pH. Is it normal? Is it acidotic? Is it alkalotic? Okay. Then we want to see where is this disturbance coming from? Is it a metabolic cause? So are there changes in the bicarbonate, or is it a respiratory in origins? Is there a change in the carbon dioxide? The one thing I haven't covered today are mixed disturbances. Okay, so you might have a metabolic acidosis and a respiratory acidosis. But I think I haven't covered that because I think it's slightly too complex at your stage, but feel free to read up on it in your own time. And compensation. So do we have any compensations? If we had no compensation, say for example, we had a respiratory acidosis. Okay, if we have no compensation, the bicarbonate will be completely normal. If we've got partial compensation, everything will be abnormal. Okay, because the CO2 or the bicarbonate will trying to counteract each other. And the pH will be abnormal as well because the body hasn't quite managed to correct the pH. And if it's fully compensated, the pH will be completely normal. So I think some of you might be asking at this stage, how do we, if it is fully compensated, how do we know whether the abnormality at the beginning was acidotic or alkalotic? Okay, so let me repeat the question. If there's a full compensation, how do we know what the abnormality was at the beginning? So how do we know whether it was originally acidotic or alkalotic? So one way of figuring that out is we know that the range for pH is 7.35 to 7.45. So you'd expect most people's pH to be around 7.4. Okay, so if it's between 7.35 and 7.4, we know that the first abnormality was actually acidosis. Okay, and then the body's corrected it. And similarly, if there's full compensation, but if there was an alkalosis before, we'll now know that the pH will be between 7.4 and 7.45. And of course, we thought about oxygenation versus ventilation. So oxygenation to do with oxygen, ventilation to do with carbon dioxide, and type 1 versus type 2 respiratory failure. So I've talked for quite a long time. Let's get on to some questions. 2A. So if I go to the next question, hide the results. And if I give you, let's say 2 minutes, we'll see how we get on. This question. So we've got a 21-year-old student that comes into A&E, sweating profusely with shortness of breath and chest pain. Could you please repeat that? What did you want me to repeat? Oh, okay, how to tell what the original abnormality is. Okay, so I'll be getting onto that just after we've done this question. So 7 of you have voted. 8 of you. So I think these questions are fairly representative of what you're going to get in the exam. They're not going to be much trickier than this, hopefully. All right. Okay, so most of you have gone with respiratory alkalosis and 1 of you has gone for metabolic alkalosis. Okay, so the answer is respiratory alkalosis. So most of you got it completely right. So let me recap this quickly because I think most of you have got it right. So the pH, we know it's above 7.45, so we've got alkalosis. So the first thing I do is check, does the carbon dioxide explain this change or not? So if it's an alkalosis, we'd expect, because CO2 is acidic, we'd expect the CO2 to be low if there's an alkalosis. And because it's 3.5 and it's below the range, we know it's a respiratory alkalosis. And just to check, the bicarb is in its normal range. Okay, it's between 22 and 26. And another point I didn't mention was actually the base excess. Okay, so the base excess actually mirrors, is very, very similar to the bicarb. So if we think about this, you know, what it actually is, base excess, do we have lots of base or not? So remember I said that if we've got a metabolic acidosis, our base excess will be very, very negative. Okay, which makes sense as well. So I think one of you has asked me, how do we know what the original abnormality is? So if I go back, here. Okay, so we know that the pH is between 7.35 and 7.45. If the fully compensated pH is around 7.36, for example, it falls in this normal range, but it's closer to acidosis. It's closer to acidosis, so we know that the original abnormality was actually acidosis. If it's around 7.43 or 7.44, okay, we know it's an alkalosis. It was originally an alkalosis. It's very, very close to 7.45. I hope that answers the question. How do you know it was always normal? So is the question, how do we know it's not, how do we know that it wasn't always normal? Okay, so essentially, if everything is normal, then we know it's going to be, there's no abnormality, okay? Whereas remember, what I said was, if the pH is normal and there's abnormalities elsewhere, so there's abnormalities in carbon dioxide and abnormalities in bicarbonate, we know that this isn't normal, okay? Someone's asked, the base excess in the question was high, so how do we know that it's not metabolic? That is a very good question. The bicarbonate was completely normal in that question. And the carbon dioxide, sorry, I'm giving the answers, that shouldn't be. So that's a very, very good question, but we know that the carbon dioxide explains this change, okay? And the bicarbonate was completely in its normal range. So the one that best fits the answer is respiratory alkalosis. So does that mean that the base excess was compensation? I don't think so, because if it was compensation, if it was metabolic compensation, we'd expect the bicarbonate to be low. Okay, we'd expect the bicarbonate to be very, very low if there was any compensation, but there was no compensation in this question. Okay, so part B of the same question: what could cause this? What could cause this derangement? Okay. I just didn't get why base excess was high. That's a good point. I think it probably should have been, 2 or within normal range. So it's probably just a small mistake on my part. But I don't think the base excess was too relevant to the question, because the other abnormalities were the cause of the derangement. Okay, so we've got 10. We normally have around 10. Okay, anxiety. Everyone's been paying attention, where everyone just really knows their stuff. So exactly, anxiety. If you're hyperventilating, you're going to get respiratory alkalosis. You're blowing off all that carbon dioxide. Okay, well done. All right, question 3. Let me open it up. Cool. All right, question 3. We've got a 55-year-old male Comes back from a very, very nice holiday in Thailand, and he's developed a fever, some diarrhea. He's extremely clammy and has dry membranes. So he looks really, really unwell, so we're going to do an ABG on him. What is the abnormality here? So this looks like a slightly trickier question. You guys are taking a bit more time. We've got 10. Okay. So if I see what you guys have said. Oh, okay. Fine. So we've got a bit of a, we've got some differing opinion. Most of you have gone with metabolic acidosis with respiratory compensation. We've got a few respiratory acidosis with metabolic compensation, and we've got one with no compensation. Okay, so I think this is one of the harder questions. So if you can get this question, you're doing really, really well. If we go through this logically again, we've got low pH, so we've got acidosis. We've got acidosis. Okay. The next thing I always do is go to the carbon dioxide. If there's an acidosis, we expect the carbon dioxide to be high if it's going to cause the acidosis, but it's not, it's low. So this carbon dioxide can't be the cause of this acidosis. Okay. Next thing I do is go to the bicarbonate. The bicarbonate is 18. It's on the lower side. And because bicarbonate is alkalotic, if we've got low bicarb, it's going to cause this acidosis. And as I said before, a little cheat is if the base axis is really negative, we know we've got metabolic acidosis. Okay, so we know we've got metabolic acidosis. And going back to the carbon dioxide, it wasn't normal either. Okay, it was on the lower side. So if we think about what this means is that we're in an acidotic state, the lungs are working really, really hard to get rid of this carbon dioxide, and that's why the carbon dioxide is low. So therefore, we've got metabolic acidosis with respiratory compensation. Do you have any questions for that, for question number 3? Does that make sense? If anyone wants me to go through it one more time, I can do. Question 4. So let me open this up. With the diarrhea, is that compensatory mechanism? So does a diarrhea compensate? So basically, the diarrhea actually could be causing this metabolic acidosis. So if we're losing all this bicarb through the diarrhea, we could actually be causing this metabolic acidosis. So let me talk about compensation again. I'm sorry for the people that want to actually do the menti, but this is quite important. If we've got a metabolic disturbance, the compensation will only be respiratory. Okay. If we've got a metabolic cause, the compensation will be respiratory, and if we've got a respiratory cause, the compensation will be metabolic. Okay, so they kind of go hand in hand. So if the cause is metabolic, which is in this case, the compensation will be respiratory. I hope that makes a bit more sense. So question 4, one person's already done it. 74-year-old lady comes into A&E with a high fever following a recent UTI. Not an uncommon scenario at all. On examination, she's a bit tacky. She's got low blood pressure and is severely unwell. So we've got the sepsis protocol, which is initiated. So if you're on firms, you might think about the sepsis 6. Okay, so the sepsis 6 is a protocol that's initiated when you see someone that might have sepsis. So I encourage you guys to look it up. And it's a very, very common exam question and something that you've got to think about on firms. So we do an ABG on this lady, and this is what we see. What is going on? Okay, so we've got 9, just waiting for the last person. Amazing. All right, so we've got metabolic acidosis. Most of the people have said that, and someone says respiratory acidosis. Good. So I think I'm a bit short on time, so I'm going to go through this a bit quicker. So our lactate is elevated. So remember what I said about lactate and hypoperfusion and lactic acidosis. Base excess is negative, so we know we've got metabolic acidosis. And our carbon dioxide can't be contributing to this. Okay. So those were the quicker ways of trying to get to the diagnosis. Question 5a. So we've got a 40-year-old lady. Okay, so we've got a 40-year-old lady that's come back from a long-haul flight complaining of difficulty breathing and calf pain. She takes the oral contraceptive pill. So we've done an ABG for some reason on this patient. And what do we see here? Someone just... All right, so we've got 10 of you. I think we had 11 on the last one somehow. Oh, okay, fine. There's a bit of a split here. Okay, so the difference between type 1 and type 2 respiratory failure, okay, is that in type 1 we've got one abnormality, which is just the oxygen, and type 2 we've got two abnormalities, the oxygen and the carbon dioxide. Okay. Now, this might be a bit of a tricky question because the carbon dioxide is low, but in type 2 respiratory failure, the carbon dioxide is high and the O2 is low. Okay, the carbon dioxide is high because you're not able to ventilate. You're not able to get that carbon dioxide out. So the answer is actually type 1 respiratory failure. Okay, so the carbon dioxide should be high in type 2 respiratory failure. So that was maybe a tricky question. Question 5b, interpret the results. You guys are getting good at this, so this shouldn't take as long. Sorry, let me open it. So I'm just really wary of the time, so I'm just gonna crack on. Okay, so most of you have gone with respiratory alkalosis. Okay, and that is indeed the correct answer. So we've got a high pH, so we've got, it's alkalotic. The first thing I always do is look at the carbon dioxide. Can this explain the alkalosis? And in this instance, it actually does, because the carbon dioxide is low. Okay, and because it's low, it explains this high pH. And everything else looks pretty normal, apart from the oxygen, of course. Good. All right, so this is the, I've given you the answer. This is the last ABG question that we've got. But for those of you that didn't manage to see the answers, we've got an ABG that's done on a 70-year-old smoker with a 30-pack history. So think about what kind of condition would be in this very stereotypical question. Someone with a very long pack history, and have a look at the options. And I know it's 7:30. Started slightly late. You probably want to go off and have dinner. So I will rattle through spirometry. Maxed out at 5, right? We've got 7, 8. Any more? 9. All right. So we've got 6 for fully compensated respiratory acidosis, and 3 people that have gone with respiratory acidosis with metabolic compensation. Okay, so maybe this question was a bit tricky. The first thing I want to talk about is the pH. It's a 7.36. Okay, so it's just about normal. It's just about normal. So if you remember what I said at the beginning, if it's just about normal, but it's very, very close to the edges, there might have been an original abnormality, and in this case, the original abnormality could have been the acidosis. Okay, and because the pH is normal, it's fully compensated. So even if you just looked at the pH, you could have got this question right, because there was no option that said normal, normal ABG. So this is a fully compensated respiratory acidosis. And why is it fully compensated? Well, remember what I said earlier on. I said if it's fully compensated, the carbon dioxide and the bicarbonate will be off, because they're counteracting each other. So the carbon dioxide is on the higher side. Okay, it's above 6. This is a patient with COPD, by the way. And you might want to think about why the carbon dioxide might be chronically high in some of these patients in your own time. But we've got carbon dioxide, which is slightly higher. It's higher than 6. That's contributing to the original acidosis, and the bicarbonate is counteracting that. Okay, so all you got to do for this question is to say our pH is in the normal range, but it's not what you'd probably expect from a normal patient, from a healthy patient, should I say. And the bicarbonate is counteracting the oxygen. Do we ever look at the oxygen? Someone has asked me. If I go back right to the beginning, I've said that oxygenation could be potentially the most important thing that you do look at. But in these cases, in these questions, the only thing I'm going through is just the acid-base disturbance. Okay, so of course in reality you would look at the oxygen, and remember the take-home message from today was, when you do look at the oxygen, remember, is the patient on any oxygen? Are they on high flow oxygen? Are they on just 2 liters a minute of oxygen, or are they on room air? Okay, so when you look at the oxygen, make sure you always look at, is the patient on external oxygen or room air as well? Okay, but that's a good question, because we really should be looking at the oxygen in all of these patients too. It's 7:33, so hopefully the next few minutes I'll rattle through spirometry. So I'm not an expert on spirometry at all, but essentially we've got a patient which is blowing into one of these machines, following a deep inhalation, and we're basically asking ourselves how much air can be forced out in one breath. And spirometry is really, really important to differentiate between obstructive conditions and restrictive conditions. So there's 3 main metrics when it comes to spirometry. There's the FEV1, okay? So this is the forced, so this is the expiratory volume that's exhaled in 1 second. There's the FVC, which is the total volume exhaled in that one breath, and the ratio between these 2 numbers, okay? And the ratio of these 2 numbers should be more than 0.7. And when I say 80% of predicted, the predicted values are derived from the patient's height, age, and gender. So essentially, you've got a patient that's exhaling in one breath. And it takes a lot of respiratory effort to be able to do this, to be able to do this accurately. Okay, and look at these metrics here. And we can use these metrics to determine the difference between obstructive conditions and restrictive conditions. So this is a graph looking at the volume exhaled after 1 second and beyond. Okay, this is the total volume exhaled. We've got the normal lungs at the top. Okay, so a nice big FEV1. So most of the air that you exhale will be exhaled in the first second. Okay, and then you're really trying hard to exhale anything else that's remaining. And then you've got your restrictive and obstructive diseases. So obstructive disease, you think of COPD and asthma. Restrictive diseases, you might think of interstitial lung disease or fibrosis. Okay, and the differences are key here. So in restrictive diseases, okay, your FEV1 will be reduced, and in obstructive diseases, the FEV1 will also be reduced. Okay, but the ratio of FEV1 to FVC varies between the two. So your ratio of FEV1 to FVC in restrictive diseases will almost be normal, whereas in obstructive diseases, patients find it very difficult to exhale. Okay, that's why it takes a long time to exhale all of this air. So it takes a really long time to go from your FEV1 to your FVC, because your FEV1 is really reduced. Okay, so obstructive conditions, we've got airway narrowing in these conditions because of chronic inflammation. And in these conditions, as I've said, your FEV1 will be reduced, less than 0.8. Your FVC will be normal or reduced, and your FEV1 to FVC ratio is less than 0.7. And the causes of these, you've got COPD and asthma, and COPD is actually, how severe the COPD is actually depends on these numbers, okay? And spirometry is the gold standard when it comes to diagnosing COPD. And I'm just going to go through this last slide. I'm going to skim through these questions because I've already taken up a lot of your time. Restrictive conditions is when the lung volume is reduced. So your FEV1 is reduced, your FVC is reduced, but crucially your FEV1 to FVC ratio is normal. Okay. So I had a question for you here. A patient with COPD, we've got spirometry. Which of these two results is most likely? And I think you'll have access to the slides, so you can probably look this up later. But as I said before, our FEV1 is reduced and our ratio is also reduced. And then with pulmonary fibrosis, an example of a restrictive condition, our FEV1 is reduced, but crucially the ratio of FEV1 and FVC isn't reduced as much. Okay. If you want some more practice, you can look at this website, abg.ninja, Geeky Medics, of course, and Life in the Fast Lane. And I've looked at Shamim's slides for some inspiration.